One. All right, so welcome everyone to this Zoom press conference. Today we're going to be announcing the formation of the Arizona COVID-19 Genomics Union. And the three presenters here today, the co-founders of this union, are Paul Keim from NAU and TGen, David Engelthaler from TGen, and Michael Warby from the University of Arizona. So you should all have the copies of the press release by now. It'll have all the spellings of their names and their titles and affiliations. After Paul and Dave and Mike have an opportunity to discuss this a little bit, then we'll open it up for questions. And you can submit questions in the chat area, which is if you put your cursor over the screen and you hit chat, you'll see that there's a place there where you can type messages and ask questions. And I'll call on y'all for those questions later. So at this point, I'm going to turn it over to Dr. Paul Keim from NAU and TGen. And Paul, take it away.
Thanks, Steve. I suddenly realized all three of us, Mike, Dave, and I, have unusually spelled last names. So that is good that you can actually look at them in writing and get them correct. But the three of us are really pleased to hold this press conference today and to inform the public about what we're doing, because you know, this COVID-19 outbreak is, of course, sweeping the world, but we need people like this union involved to make it relevant and to leverage what's happening elsewhere in the world here in Arizona. And so what we're doing is we're taking advantage of genomic technologies and people who are at different places in the state of Arizona to coordinate and collaborate in a way that can be done through the internet. This is all about data and tracking the disease around Arizona and how it comes to our local communities. And it's actually an ideal application of what we call dispersed collaboration. And so, you know, we have three different institutions right now, but we're bringing in others every day. And so this dispersed effort is going to really make an impact in how we understand the disease and address the outbreak here in Arizona. Dave, do you want to pick up on that and make a few opening comments?
Sure. Thanks, Paul. It's great to be with everybody today and talk about this formation of this union and actually what the purpose and the point of what we're trying to do. At TGen, we've obviously been working on this COVID-19 response, and there's been a lot of discussion about the testing and all of that. But there's also a lot of great science happening in this state and around the world, but especially in this state. There are some truly great leaders that we're able to bring together to be part of this union. And obviously, Dr. Paul Keim, one of the founding fathers of microbial genomics, and Dr. Mike Warby, who's internationally renowned on understanding viral evolution using genomics, and then a lot of the great work that's happening at multiple universities and certainly within TGen as well. So we're bringing this to bear, not just for the purposes of research and to further our understanding on the science side, but to also make a real difference in the response. This information is going to be used by public health officials and already is, to better understand this virus and how it's moving around and where it's coming from and maybe where it's going. So we can talk about those pieces as well. Mike, I'll toss it over to you.
Yeah, thank you. I just want to start by thanking Paul and Dave. And it is a real honor and pleasure to be able to work with you guys and the rest of the team that we've assembled from our various institutions. It's really exciting to be able to do this kind of work. And so what we're doing here is sometimes called genomic epidemiology. And it's really the 21st century advance in traditional epidemiology. It combines a lot of traditional epidemiology, but it adds this component of being able to look at the gene sequences of things like these viruses. And when you assemble enough of them from Arizona, from Washington State, from New York, from Europe, from China, you start to get this picture of how these viruses are moving, spreading, starting local epidemics, how often new things are jumping to a new area and taking off, how often you just have a sort of one-off dead end that kind of doesn't go anywhere. And so just over the last weeks of being able to collaborate as part of this union, we've gone from really not understanding much at all about what's going on to adding this huge component that we'll talk about today that comes from the genomic perspective that tells us a whole lot about what's happened and, as Paul said, where things might be going.
So that's great. With that kind of preamble, we'd be glad to answer questions that you might have. So Steve, do you want to moderate?
Sure. I see. I don't see any chat questions as yet, and not everyone is visible to me at the moment up here on the screen. So I guess at this point, absent that, if anyone has a question, if you could just go ahead and chime in at this point.
I've got a question, Steve. So I guess my question is twofold. First of all, I'm not sure if you guys have gotten a chance to analyze more samples from patients. And I know David said something about this is going to be used by public health officials. It's already being used by public health officials. And I'd like to see if you could expand on what you meant by it's already being used and kind of what the data we have right now is based on how many samples. And then the second part is I wanted to know if you could expand a little bit more on how this is different than each university and TGen working on their own and kind of what bringing everything together really does to enhance everything. Like I know obviously collaboration is important in science, but if we get more specific, that'd be great.
Sure. I'll try the first part, and I'll let Dr. Keim take the second part, and Mike can jump in too. So we're already have sequenced well over 100 of Arizona's first cases, and we are receiving samples regularly, multiple times a week, coming in from the state lab and also from other testing labs, the positive samples, so we can do that sequencing. How that data is being used right now is we can see that strains are coming from different parts of the world, and they're doing what was described. Sometimes we see these one-offs, and then there's no other cases from it. And then sometimes a case will come in, or a strain will come in and actually spread like wildfire, like you would expect. So we know the virus didn't just come into Arizona and just roll across like a tidal wave. What's happening is it's coming in spurts and starts in different places. We can track what states they're coming from or what countries they seem to be most related to. And then we can also see which ones are actually causing outbreaks that need a lot of attention, and other ones that seem to fizzle out and not go on and cause additional cases. And this information, as we generate it, as this union generates it, we turn it over to public health. And then public health is actually able to use that to see, do we need to put resources around this because it's a growing cluster, or we see that this one-off case didn't have any other subsequent cases tied to it.
Yeah, that's great. So as Dave's saying there, you know, these patterns are being observed and monitored at the state level to understand what's happening. You know, what's important about having more than just one laboratory involved is that these sequences are being generated all around the world. You know, we see sequences from Washington State, New York, Europe, China. And likewise here in Arizona, they're being the sequences, well, at this point, I'd say TGen is generating the most sequences. That's not universally true. They're being sequenced at different institutions. And by sharing those in a way that's very transparent, we get a community buy-in for what's happening. You know, it's very important not to be secretive in an outbreak like this, but to be transparent and have multiple eyes upon what's happening. And I think that was really important for all of us to see what was going on in China very early on, because we could start to infer what was happening without having somebody else interpret it. You know, the last thing we want is for the Chinese government to tell us about what's happening. We want to be able to look at the data and understand it ourselves. And so this union allows that level of transparency and data sharing that is really important. Mike, maybe you could say something more about specifics of what we're seeing in Arizona.
Yeah, I'll do that. I just want to first add to what you said about this idea of open science. At a time like this, when we've got a pandemic and a huge challenge, these gene sequences are not only important for tracking, they're also telling us about the genetic diversity of the virus that we're going to have to contend with therapies and vaccines. And so part of what we're doing is contributing to that effort. And during a time like this, the normal academic model is just not what you want to do. You don't want to sort of keep your data to yourself and sit on it for months and polish a nice publication. You just want to drop all of that, work together as much as possible, and generate data that we can publicize like we're publicizing today. So in terms of specifics, one of the really key inferences that have been made with this pandemic so far was made up in Washington State. So early on, back in mid-January, the very first US COVID-19 patient was discovered in Seattle. And this is someone who had traveled from Wuhan, China to Seattle and then became symptomatic. So that's about January, that is January 15th that individual entered Washington State. 6 weeks later, colleagues of ours up in Washington State sequenced the second complete genome from Washington State 6 weeks later. And what they found was on this evolutionary tree, which has dozens and dozens of different branches, of all of the branches that second genome could have fallen on, it fell on exactly the same branch that the first one back in January was on, which showed that that January one most likely established itself and started spreading cryptically for 6 weeks before anyone had noticed it. So one of the first things that we wanted to do here in Arizona is ask the same question, because we had one of the very earliest cases in the United States as well back in January. And we now have several genomes from Arizona. And so the first specific thing that we were able to show is no, that first patient did not appear to establish a chain of transmission that cryptically circulated in Arizona. We see other transmission chains, and there's one major transmission chain. Again, it's off on a totally different branch than that first one. So it's come in independently, and it looks like ultimately it has its roots in the European outbreak. But there are also variants of that same transmission chain that we can see in Utah and other US states. So whether it came directly from Europe to here or to some other place in the States and then got a foothold here, there is this one major transmission chain that we're seeing in Arizona, but quite a few other independent one-offs or smaller transmission chains.
Okay, so folks are sending in some questions via chat, and I'm going to go ahead and ask those for folks. So one of the clarifications you wanted to see is, are all the samples that you'll be sequencing coming from Arizona or from elsewhere?
Yeah, so right now, the vast majority of what we're working on are samples that originate in Arizona. We do have some individuals who are travelers from outside of Arizona. They show up in an Arizona hospital or they get sick while traveling or visiting somebody, and they're bringing in strains from elsewhere. So we're trying to track that down, working with public health, where those individuals come from. But our focus with this union is Arizona, and we're working as part of a national system. And one thing we failed to mention, the Centers for Disease Control is coordinating a number of sequencing centers around the country, and they're just starting that this week, and we're an active participant in that as well.
Is it possible to tell as yet which areas of the valley here around Phoenix have the most cases or any clusters?
So I can speak to numbers of cases and clusters, and and then maybe Mike, you can talk a little bit more about the genomic results there. The vast majority of cases, no doubt, are in Maricopa County, and that's where the vast majority of people live. But when we look at rates, which is when you look at kind of a proportion of the population, the hardest hit places are more rural counties, our northern Arizona counties, and our tribal communities. Those have the highest rates, but the largest number of cases are definitely showing up in the population centers, as we would expect.
Yeah, and so just to add to that, we do have several cases that have come from state public health, and we don't have a full picture actually on exactly the geographic locations of all of those yet. So we're not in a position yet to talk fully even about the different geographical patterns across the state, let alone in Maricopa County, but we expect to get there very, very soon. I also want to point out one other key thing that we've already learned. So from these evolutionary trees, when you have a sort of branch on the tree that has a lot of genomes in it, as we do with this one major outbreak cluster that we're seeing in Arizona, you can place a date on when that emerged. And what we're finding is it's looking like at least by the beginning of March, that outbreak clade had already established itself in the state. And I think this is one of the powerful things that come from analyses like this. You know, all across the states, people have been trying to decide, when do you put in these measures for social distancing and these things that can slow the outbreak down? And what these genomes are telling us is the traditional epidemiology tends to lag behind what's actually happening on the ground. And these genomes are telling us that before we took really extensive measures statewide, this virus was already established and transmitting successfully in a transmission chain. And we expect that to just be sort of happening more and more now. And so these are sort of a glimpse into what's actually happening, which you don't get with the traditional epidemiology, which is sort of an echo of what was happening a couple or 3 weeks ago.
Michael, just building on that, could you explain what you mean by traditional epidemiology?
Yeah, so identifying actual cases, looking at the number of hospitalizations, looking at the number of deaths, all of these things are crucial, and they're in a way they're the important thing, particularly deaths, but they're a lagging indicator. They're telling you about the actual transmission events weeks ago that led up to those people becoming sick and going to the hospital, and unfortunately in some cases dying. And so genomics allows in some ways to go back in time and have a look into what was actually happening when things started really cooking and transmitting.
Yeah, if I could add just real briefly to that. So Mike is talking about the molecular clock and how we can track back on these things. I would point out that Arizona's infrastructure involving high capacity, high performance computing is really important in this. This type of modeling that we use, evolutionary modeling, can tie up even the largest supercomputer for hours, if not days. And so the investment that the state of Arizona has put into that infrastructure is really critical in this crisis.
And Steve, if you don't mind, I want to add one more point based off of what Mike was saying, and he mentioned this earlier. What we're doing is really creating 21st century public health. We're bringing genomics in to be able to empirically understand relationships between pathogens that, you know, before we were just using the best information to really guess at, and now we know what strains are related to each other. We know how these organisms are moving around, or how quickly they're moving around, or how quickly they're evolving and changing. We couldn't do that before we started bringing in next generation science and technology. So this exercise is important for this outbreak, but I think it's really going to change how we think about public health into the future.
A follow-up question on that. Is this computer system that we're going to be using a quantum computer or a supercomputer?
Oh, I don't think we have quantum computers online quite yet. So these are supercomputers. But again, you know, University of Arizona, TGen, NAU, we all have these large clusters now that are necessary to do this type of analysis, and especially the really detailed molecular evolution that Mike was talking about really does require these big computers.
And Steve, can I just jump in and now add to one thing Dave said about 21st century epidemiology? What we're going to be able to do as we get more of these, and we're pretty much now at the point where I think we have enough genomes to start doing this, is you can tell on these evolutionary trees not just how these different strains are related, but you can actually make what used to be sort of the realm of traditional epidemiological inferences, such as if you've got X number of people infected in the state, how long until that number doubles? That's a sort of traditional epidemiological thing that you want to look at. You can actually infer that directly from these gene sequences. So we're going to be able to look back and say, okay, over this last while in March, when things were growing without much social distancing, how fast was this epidemic moving? How quickly was it doubling? And after the stay-at-home order was put out by the governor, then we're going to be able to see what's the effect. How we expect that to slow down the doubling rate, and we've seen good evidence in Washington State and California that that's the case. We'll be able to actually scientifically test that and hopefully show some nice evidence that these effects or these measures that are so painful are actually having the effect that you would want.
That's a great.
My chat is broken, so I just kind of can't type, but I just wanted to jump in and ask a follow-up to that. Two follow-ups. One, is that what the university part of it is, taking the sequences and doing that analysis and making those inferences? And two, now that you've mentioned it, I'm sure we are all curious whether there are any inferences that you are able to say yet as to, you know, how fast, when we might peak, that kind of thing, or any other inferences you might be able to give us?
So all of the analyses are really being done by all of the institutions in the union together, and we're bouncing ideas and data sets off of each other on a daily and hourly basis. The bulk of the vast majority of the actual sequencing is being done by TGen. We've done a little bit of sequencing down here in Arizona as well, and are hoping to add more to that effort. But TGen is the real powerhouse, and we're really lucky to have that. And I think it's fair to say, Paul and Dave, that Arizona's punching above its weight in terms of the number of genomes that we've now been able to put out compared to many other states, which is great to see. And then what was your second question?
It was just about whether there are any inferences that you can share with us, especially since you already mentioned some examples of inferences you're hoping to make. I'm wondering if you guys do have any inferences as to when we might have some sort of peak or kind of anything that you can give us on any other inferences you might have.
So the doubling time inference we'll probably have within a few days. But these models are not really the kind that are going to tell you when to expect the peak number of deaths, for example. Those are more traditional epidemiological models that these gene sequences don't necessarily give you access to.
Steve, if I could add, you know, the other advantage or importance of monitoring these genome sequences is when we're talking about these changes, we're talking about mutations that occur in the genome. And of course, those mutations right now we think are mostly neutral. They aren't changing the biology, but they could change the biology in time, and they could certainly change our ability to monitor this outbreak via diagnostic tools and have implications eventually for the efficacy of vaccines. And so we don't see anything like that right now, but we're watching for it to see if these mutations are going to change our ability of our diagnostic tests to work and whether they have the potential to affect our vaccine strategies in the future. We're still in the very early days of that, but it's really important to be watching. We got to go into this with our eyes wide open.
So question, are you trying to sequence all of the Arizona cases that, that you have?
We have the capacity to absolutely sequence every single Arizona case, and that is our goal. We know some just won't get in the system, but we are working hard to make sure that we can get all those into the lab and sequenced and be able to share that data, not only with the union, but then globally with the genomics world that's looking at this closely.
And that's looking at all the positive cases from the simpler PCR tests.
That's correct.
Okay.
And can you hear me, Steve? This is Dennis over
Yes,
at
go ahead.
CGS5. You know, all this is really impressive. You're getting this group together using the latest technology and whatnot. But I think, you know, our viewers kind of interested, where does this all lead? Does this lead to a vaccine? Does this lead to some sort of, you know, cure, for a lack of a better term? I mean, what's the end game here?
Let me take a quick swing at that, Dennis. So we're learning a lot right now about what's happening with the virus here in Arizona, as well as across the country. And the genomics that we were describing tells us that we are likely to see very similar patterns, even after we get past the peak and the number of cases, and that starts to drop off. This virus will still be around and will likely cause one-off type outbreaks. And it's very important for us to be able to provide this information for public health to respond quickly. As we move through the summer and into the fall, my guess is it comes back again. Once it gets, after we get past this peak, it'll come back in the winter. What we're learning right now, and the models are telling us, there's gonna be somewhere between 80 and 90% of the population that still is gonna need to be infected or get vaccinated. So there's still gonna be a fair amount of disease. And these tools, as we're making this routine and making this part of the process, is going to provide this real-time genomics solution for public health epidemiology. But then all that other data that's being gathered and generated is being looked at by the vaccine makers, by the scientists that are looking for new antiviral drugs. Every piece of this adds in another layer of information that'll be useful for those pieces of the response as well.
And I can add just a bit more to that, practically speaking. So I've got colleagues who are developing the immunological assays that will start to be able to tell, if you take a blood sample from a person, do they have antibodies that are actually going to neutralize the virus, which would prevent them from being reinfected with a given strain? The next part of that research is to try a bunch of different strains of the virus. As Paul said, we don't think that the variants that have accumulated so far are likely to be antigenically different enough that a rare strain might be able to escape that person's antibody response and reinfect them. At some point, though, that will happen. And it's by accumulating more and more of these genomes that you can then actually do those tests. If you don't accumulate the genomes like we're doing here in Arizona, then you're blind. You can't actually tell what you need to tell with the kind of immunological experiments that will need to be done to be able to ascertain, once we have a vaccine, is it going to protect against all strains or only a portion of strains? Do we need more than one vaccine? All of these questions, we're laying the groundwork now for what unfortunately is likely to be years of work in the future.
This is a question for Dave. I was wondering if you could break down in basic terms the process, how you get the samples, where they're coming from, then the process of then sequencing. How does all that work?
Yeah, so we're using a number of different technologies right now to make sure we can get complete genome sequence out of samples. We get a sample in our diagnostic lab or in our screening lab that is positive. that sample automatically gets rolled over into the sequencing lab, or we'll receive samples in from the state health department, the state public health lab, or from other commercial labs. Those go into our sequencing lab. We extract the genetic material, which is RNA, which is essentially the virus's version of DNA, and we essentially prepare that to be able to sequence out each of those individual letters of that genome. And I'm not going to get too far into the technology, but we're actually we're tackling it from a couple different angles to make sure that we can get the best genome sequence data out of those particular samples. And then that data, essentially, it's digitizing the RNA. It's turning the A's, G's, T's, and U's, in this case, into ones and zeros. We share that easily through internet sources with each other securely, and then are able to do the types of analyses on our respective servers and supercomputers, and then provide that data out to the world as well.
Remind us real quick, how many genomes have been sequenced so far?
In Arizona?
Yes.
So we've just today have gotten us a little over 100 genomes. We'll probably be over 200 genomes by the end of the week. And then we're starting to make sure we get receipt of about 100 genomes at a time. So we're going to start, hopefully, be doing 100 to 200 every few days in Arizona.
So another question is about reports that some subjects have tested negative for COVID-19 using PCR, despite having symptoms, including, well, a number of them that are consistent with the coronavirus. Upon retesting, their PCR came back positive. Can your work help overcome the problem of possible false negatives in testing?
Paul, do you want to start with that one?
Yeah, so all diagnostic tests have a certain rate of false positives and false negatives. In this particular case, what we know is people will be shedding virus. And so the PCR test is actually looking for real viruses that are in your respiratory tract. And so you can show symptoms and not be shedding virus, either because you're past the peak or because you're before that. Now, there's a lot of unknowns here. This is a brand new disease, and so we're still trying to figure that out. And so the test is incredibly sensitive. I mean, this test can see like only 2 viruses. So if we get 2 viruses in the tube, we can see it. But sometimes you just aren't shedding virus. And if you aren't shedding virus, this particular test will not detect that. Now, Mike was talking about these serological tests. We're actively pursuing it, as probably another 100 groups around the world are. Those tests will help us to confirm after the fact, as you're starting to recover, whether or not you've actually had the COVID or had influenza or something else. And so it's going to take a battery of tests to figure this all out, but the PCR test is amazingly good, but it's not 100%. Dave?
And by serological, you mean blood or plasma tests?
Yeah, so we'd be looking for antibodies that you have produced in response to that pathogen. TGen actually has an incredible assay that will test for every known human virus and look for antibodies for everyone but the CoV-2, and that's because the CoV-2 is brand new, but that's being fixed and rectified. So in the future, we're going to have these tests that can go and look and see if you've ever been infected by any human virus and be able to tell what your past history was. And that test is just a few weeks away from being in place. But that's going to be really important for guiding efforts in therapeutics, using antibodies for therapeutics, but also for the efficacy of the vaccine.
Yeah, and one other thing to add into that, to point out the importance, not to distract too much from the genomics, but of the serology testing that Mike and Paul have been talking about. It's going to be what we all have to do moving forward. It's going to be the measure of can we get back to work? who's protected in our healthcare, in our emergency responder system, but also who may have been infected and is now healthy, can get back on the line, and you're not going to risk losing them during the next upcoming COVID-19 season. So these are incredibly important tools that are just starting to come online, but they're going to be important for years to come, as Mike said.
Okay, question. There was mention of a particular strain that seems to be dominant in Arizona. How is it behaving? How quickly is it moving and changing? Can we tell anything yet about that?
We still don't have quite enough genomes in the current analyses, although as Dave mentioned, there are so many more genomes in the pipeline that we expect to be able to fill that lineage out with enough sequences that we can start making those sorts of inferences on over, say, the month of March. What was the doubling time of that particular outbreak? So stay tuned, and we'll have that sort of information soon. Its dominance, I think it's really important to point out that its dominance is almost certainly just a chance sort of alignment of the stars in the right place, that someone with the virus entered Arizona maybe in February or March, and that it just sort of landed in a pretty efficient chain of people transmitting it one to the other. There's no evidence whatsoever that there's something special genetically about that lineage. At this stage, as Paul said, functionally, we think all of these viruses have the same ability to infect people. So when you see a dominant lineage, it's just telling you that by chance, that one got in early and got a foothold. It could have been some other one genetically, it just happened to be that one. And we see this in other places. Washington State has a dominant lineage, a different one, and it accounts for about 85% of the genomes they've sequenced there. And other countries and states have different dominant lineages, again, just reflecting chance events.
And just to reiterate, the dominant strain that you've seen so far in Arizona is coming from where?
Ultimately, all of these, of course, go back to the Chinese origin of this outbreak. This lineage then made it to Europe and established a foothold there. And so it's come from Europe into North America. We're seeing it not just in Arizona, but as I said, in Utah and a little bit in Washington State as well. So it's possible that this came just from another American state rather than from Europe to Arizona directly. And that's why it's important that all sorts of other places across the world and across the country try to do the kind of work that we're doing here and pump out a bunch of these genomes, because it's not until you have really full sampling that you can fill in the gaps and say, okay, this is exactly what happened. At this stage, we have to be fairly aware that we don't have the full picture, but it's a European lineage. Whether it came directly from Europe to Arizona, we're not sure yet.
When did it establish?
The dates that we're getting are looking like the beginning of March.
And then also, patients who have provided these samples, will they be updated with the genomic information that you develop?
So the genomic information really relates only to the virus, and without any information or thought that there's a medical importance to get information back to patients or physicians, we're actually just including it all in the epidemiological analysis. So if we were to find something that seemed unusual, we would work with public health and get that information out to the healthcare provider community. But for now, what we're trying to do is develop actionable intelligence that goes really to the public health officials, goes to policymakers, goes to vaccine developers and drug developers and the researchers as a whole.
So then are we lucky, if you will, that the first case in January didn't spread like the one that has in March?
Go ahead, Mike.
Dave.
Oh, as an epidemiologist, I'd say we're absolutely lucky we didn't follow the same situation that Mike described in Washington, where we had a lot of underlying disease, because then once you find it, you start finding it everywhere. And it looks like we had a bit of a break between that very first case in January and then the subsequent cases. The other thing I just wanted to say that we're lucky about is that this outbreak is occurring now at a time when we really do have next generation tools and technologies to bring to bear. We rapidly got tests out. There were slowdowns with the CDC tests and all that, but it still went faster than anything's ever been done before. And now all of the newer technologies, the sequencing technologies, some of the advanced serology technologies that's going to help with vaccine design, that wasn't around before, and it's actually being brought to bear. So I'd say we're lucky in Arizona, but I think globally we're lucky that this is happening at this particular time.
So are there many more coalitions like the union that you have formed here in the United States and globally?
As I mentioned, the CDC just started their coalition this week of sequencing centers and folks that have worked with CDC for years, and we're part of that. And so this union is part of that. And I'm sure Paul and Mike, you guys are engaged with a number of other researchers that are developing these types of coalitions as well.
Yeah, absolutely. I have collaborators around the world who are working on this. Some of them working on the molecular biology methods to actually efficiently sequence these whole genomes. And actually, I'm one of these networks is called the Arctic Network, ARTIC, and they send out molecular biology reagents to help amplify the complete genome of the virus in a bunch of little tiny overlapping chunks where you have 100 of them, and then it makes up the complete genome. And that approach actually goes back to work that we did here in Arizona in my lab, trying to recover some of the oldest or the oldest HIV genomes from patients in the United States, where the genetic material was really damaged, and we came up with this idea of tiling across the genome. And my collaborators in the Arctic network then borrowed that technology. And I know Dave has been using that sometimes for amplifying some of the genomes in his lab. The genome of the virus that we recently sequenced in my lab, we used that same approach. So this is very much an international collaborative effort at every level, from the molecular biology to the sequencing of the genomes, to the analyzing of the genomes, to integrating it with traditional epidemiology and public health. So that's one silver lining of a bad situation like this, is it brings out the best in people around the world.
And then another follow-up, the first patient with that dominant strain, where was that person in Arizona? Can you say at least what county?
Well, what we do actually is, I'm not sure which person is the earliest one in that cluster, but really it's the cluster as a whole that then allows you to make an inference about an early patient that must have had the virus back in early March. We don't have a direct access to that. But because we have a sample closer to the present, we can use this evolutionary tree to then work back in time with quite a high degree of confidence and have insights into something that happened before we were even collecting samples, which is the cool thing about this kind of analysis. It allows you to go back in time and figure out what happened, even though you don't have genetic samples from the deeper time points.
So are some of the strains associated with a higher rate of hospitalization or even death?
We don't have any evidence that that's the case at all. We think the higher rates of hospitalization and higher fatality rates are 100% a human factor. People who have high risk conditions, the elderly, those with cardiovascular disease or diabetes or lung disease, these are the ones that are most at risk, the ones we need to protect the most on the public health side, build walls around them as the rest of us are going through this outbreak. But we don't think that there's any information to suggest that anything with the virus itself is causing these different rates of infection or fatality.
Okay.
Yes, Steve, if I could just add a little bit to that. You know, this is really a recently emerged pathogen. I mean, this thing came out of an animal reservoir sometime in the early winter. And so the differences that we're observing are only possible because we have this high resolution and very precise genomic analysis. These are very, very subtle differences that we use to track. And so these mutations are kind of like breadcrumbs for us. We can follow it back. You know, Hansel and Gretel were dropping breadcrumbs. We're trying to follow those breadcrumbs back to the source. And the differences are so subtle, we don't think that they have real biological or healthcare impact at this point.
Down the road, do you think there's the potential for finding correlations between disease strains and patient outcomes?
Sure. If in fact these mutations start to have biological impact, Mike has already mentioned that we're watching the antigens, you know, the proteins very carefully, because if those mutate and if the ability of the virus to adapt to humans increases in some way, that adaptation, this evolutionary process could lead to strains that are more deadly. And we see that in other viruses, but at this point, there's no evidence that that's happened.
And at the rate that this evolves, just to give you some specifics, this genome is about 30,000 nucleotides long, 30,000 A's, C's, G's, and T's. From the ancestor back in November or December, if you look at all the thousands of genomes that have been sequenced worldwide, the most you'll see is about 10 or 12 mutations that have accumulated across those 30,000 sites. So, you know, sort of one in 3,000 nucleotides of the genetic architecture of this virus has changed. And we don't think that's enough to matter functionally for how the virus does its job, or antigenically for how our immune system sees. All of these are going to look the same to our immune system at this point. And it's a reasonable guess that it's going to take a couple years at least before antigenically different strains evolve enough to be seen differently by our immune system. And so this is one of the reasons it's important to really go as fast as we can with the science now, because we're in this sweet spot where if we do develop a vaccine, it's likely to work across every lineage in the world. But if that takes too long, that's going to become more challenging. And I still think there's a chance with a really good vaccine, if we can push it out in a year or so and get it out to a huge number of people in the world, it's still not impossible that we could drive this thing into extinction, but it's getting less and less likely and more likely that it will establish itself as another virus like influenza that we have to be concerned about year to year.
Another follow-up here. Approximately what percentage of the samples are on Arizona's dominant chain? Or can you really tell with the limited number of samples that you've sequenced so far?
We can tell there might be some biases in the data geographically. Again, we're not too sure how well we're covering the whole state. I'd have to go back and look. I think it's still less than 50% that are falling in that dominant clade. Dave, do you recall having looked at it recently?
No, I agree. I think it's less than half. And as we get the next couple hundred coming off, I think we'll be able to have a better understanding as to what percentage of overall cases fit into that lineage.
Yeah.
Okay. That's all the questions I have from the chat. Are there any other questions that folks want to jump in and ask?
Yeah, can I toss one in right quick, Steve, here? It's Peter from KTAR. Really quick, just wanted to know if genomic sequencing will aid in the faster creation of tests for COVID-19 and all its various strains, and do we need extra testing, different types of tests for different strains of COVID-19?
Dave, that's you.
Yeah, so the simple answer is yes. Absolutely, genomic sequencing is what allowed us to develop tests really rapidly. When we first saw these coming out of China in January, TGen was able to use some of that very initial genomic data that was published by Chinese scientists and develop tests that have proven to be incredibly sensitive and specific. And that's what the world has been using. And the continuation of the development of these sequences means that we can keep going back and checking, will the assays continue to work, even with these minor changes we're seeing, and then verify that it will. So at this point in time, we don't see a need for additional tests. The vast majority all seem to be working really well, but it is something that we're going to be watching with these sequence data to make sure we can do this, what we call in silico validation of the tests continually.
Okay, one more follow-up question here. There was mention of a potential second wave in the fall or winter. Is that due to something special about the COVID-19 virus?
Now, I'll just start real quick and others can jump in. I mean, we don't know if there will be, but I think it's looking more and more likely as a lot of places are kind of getting over the top of the curve or even flattening the curve. It's limiting the total number of cases, limiting the total number of overall infections in the community that will likely peter out by summer or at least drop to a low level. That means there's still a whole lot of our population that hasn't been infected, and they're going to be primed to be infected. This virus won't disappear. We think it's moving down into the southern hemisphere like other respiratory viruses do for their winter, and it'll be right back. If it does drop down to low levels, it'll be right back once the cold weather comes back.
Yeah, and there's no doubt that, what we're seeing now is kind of low-hanging fruit for the virus. There are situations, like big soccer matches in Italy, which we just weren't aware that the virus is present. And those type of events, I think, are going to be we're going to mitigate it in the future because we're just not going to do those types of things. So these behavioral changes that we're experiencing now are pretty extreme, but we're not ever going to go back to normal, in my opinion, at least not this generation, not people who've lived through this. We're not going to go back to those same type of situations where disease can rip through our population the way it has in the last 3 or 4 months.
I just want to add that I'm still pretty concerned that the hope that this will sort of diminish because it's hot in the summer might not come through as much as we might be expecting, because there's virtually no immunity to this virus. It's going to be my concern is that with all of the talk of reaching a peak and then going down that we've had in the last couple of weeks, that what we might see more is sort of, as Andrew Cuomo has been saying, a plateau rather than a peak. And even in places like California and Washington State that were amongst the very earliest to put these social distancing measures in place, you're seeing a slowing of the doubling time, but you're not seeing necessarily a crash in the number of people infected. So my concern is that there's actually going to be a slow build through the summer, and then we're going to be in a difficult spot in the fall. And that's why everything we can do now to prevent transmission is really important. I don't think the talk of reaching a peak should allow people to think that they've got a couple more weeks of being careful and then it's back to normal.
Just a couple things. This is Dennis over at CBS. A couple things to kind of circle back on. I think Michael, you mentioned something. This might establish itself as another type of like pathogen, like the flu. Does that mean like, no vaccine in the future or something similar to like the flu vaccine that people are encouraged to get? And then
independent of whether we have a vaccine, there's a good chance that so many people are now infected in the world that even if we rolled out a vaccine to many, many people, it would still find enough people to move from person to person and then become a seasonal pathogen, one that jumps initially from animals, but then perennially travels around the world in waves. And so that may well be what we're dealing with here. The one good thing about that is one way or the other, through either infection or vaccines, eventually most of the world is going to have some experience immunologically with this virus. And we're going to almost certainly then see the case fatality rate drop way, way down. So if this does become something that we still have in 5 or 10 years, it's not, I don't think it's going to be quite as devastating as it is during this first wave when no one has any defense against it.
And then also one other comment that was made about we won't be going back to normal this generation and whatnot. I just kind of wanted to drill down a little bit on that, on more on what that looks like, what that means, that we don't go back to, before this virus, before this viral outbreak.
Hygiene. It's all about hygiene. And, I think that we're going to change our behaviors in lots of different ways. But everybody's going to be washing their hands and their surfaces, and people are going to be much more reticent to shake hands and give two-cheek kisses in the future.
And I think we might also just see more of a willingness for people who do think they might have a respiratory infection to throw on a mask, like people are much more used to doing in Asian countries. This is important. Masks are not just for preventing incoming viruses from establishing. They're also really useful, and particularly for this virus, it's clear that masks are important for preventing outgoing viruses from infecting the other people around you, including before you even know you have the infection. So even if we all just tend to throw on a mask more when we're concerned about respiratory infections, that'll have a big impact, not just on this, but on influenza and RSV and parainfluenza virus and all sorts of other viruses that cause colds and respiratory illnesses.
And self-quarantine may be one of the most important things. In America, we're quite proud of our work ethic, and a lot of people will try to power through an illness and go back into work. In the future, that's just not going to be socially acceptable. Working remotely is another thing that's definitely changed. People who didn't work remotely before now know how to. And if we can just enforce self-quarantine, we're going to have an impact across many, many different diseases, not just the COVID.
Can somebody speak to the whole curve thing? Because I think a lot of people believe that once we hit the peak and go down, that's it. Because nobody, none of our, I guess, public officials are really talking about this second wave. But if somebody can give us kind of a succinct soundbite warning that just because we peak and come down, it doesn't mean, COVID-19 is over.
Hey, Nicole, let me jump in, and then maybe Mike can respond since he brought up this topic. So I absolutely think that we will see a bit of plateauing, like the top part of the curve is going to be flat for a while before it drops down. And we're going to see this virus hanging around during the summer, there's no doubt, and it'll probably cause some outbreaks and continued heartbreak throughout the summer. but I just think that it's really difficult for some of these respiratory viruses to spread very easily in the hot summer months, especially down in the Phoenix area. But it doesn't mean it goes away, and it will linger, and it will likely be building, and will, you know, because most people are not getting infected right now, there's still a whole lot more people to be infected once it goes back on an upswing. So I don't think we're going to have continued lots of cases. I think it's going to drop, but it will be around and probably hit us hard again come fall.
Thank you.
All right, so we've been going for about an hour now. Zoom was kind enough to give us some extra time here. And so just want to check and see if there's any final questions.
All good here, man.
All right.
Good. Thanks for y'all's time.
Thank you for doing this. This was very convenient and helpful.
Thank you, yeah.
Thanks for joining us.
Okay, again, we'll try and get that recording of this session up on the tgen.org website. It'll be at the top of the press release, so you can find it eventually later this afternoon by going to tgen.org/news. And when you get there, it'll be the first link will be the press release about the formation of this union. And we'll include the link to this recording up high in that press release.
All right. Thank you, Steve.
All right. Thank you all. Really appreciate you all coming on board, and thank you.
Really good info.
Thank you.
Okay.
Bye.
Thank you. I can't, my computer's frozen, so I'm not going to be able to log myself off, so I'll just wait for the meeting to end. But thank you.
Thank you all.